Welcome back to the Voices of Healthcare Equity in our two-part episode with Dr. Neda Fuddle. I am going to continue our amazing conversation about healthcare equity, infectious disease, Project Echo, and more. In part one, Dr. Fuddle talked to us about her early life in Sudan and then coming to the United States and focusing on infectious disease and HIV, where she saw a oversized burden in East Africa, with 70% of the cases of HIV being in sub-Saharan Africa, with only 12% of the global population living there. We talked about how inequities in the healthcare system exist across the healthcare system, but they can be especially glaring with certain infectious diseases, HIV being one of our early lessons in global health inequity, and then most recently, COVID as well. And how there have been amazing advances in HIV treatment from a deadly disease within a few years with really awful complications that current physicians and students don't even see, that were so commonplace at that time, like PCP and TB and Kaposi sarcoma and pneumonia and all the things that people died of very rapidly when their immune system was decimated by this virus, to now being a disease that people take medication with zero viral loads and very little chance of even transmitting to a child if you're a pregnant woman. Really amazing progress in the science of HIV treatment, but that has not translated. That has not translated to places like Sudan. And maybe we will start there. We have these amazing advances in medicine. We can essentially eradicate transmission of this disease if everybody was on antiretroviral treatment. And if we could just get everybody tested and be on antiretroviral treatment, we would stop the chain of transmission and growth of this disease. What are the factors? What are the roles that different things are playing in keeping that from happening? I know the cost of these medications is definitely one of those factors. But what are some of the big geopolitical issues that are keeping that from occurring?
Well, so there's so many factors, and I think HIV is a very complex disease. And your point earlier about how we actually created the stigma around this disease, you know, 30 years later, we're still facing the same issues that we were talking about back in the 1990s and even 1980s when the disease first started. And that stigma has not really been, we haven't been able to eliminate that. We haven't really been successful in doing that. And that's a barrier to testing. It's a barrier to linkage to care. It's a barrier to being retained in care. It's a barrier to taking medications as well, because even in places where medications are accessible, we find patients afraid to even take their medicine in front of their family members or somebody finding their medication bottles, etc. So that's a global issue when it comes to HIV stigma. It happens here. It happens almost everywhere around the globe. In some places, HIV is associated with injection drug use, and that becomes a big stigma as well. In some places, it's associated with commercial sex workers. In some places, it's associated with gay men. And there are so many societal, social, cultural, religious factors that can create even multiple more stigmas than just the disease itself. So that's I think is the biggest barrier. There is others, of course, such as access to medications, access to care, access to testing. Those are real issues that happen, unfortunately, everywhere. Even here in the U.S., there are issues around, even with the Ryan White program, which is probably one of the most successful programs in this country when it comes to public health interventions. Even with that, we find patients sometimes having a lot of challenges just making it to the clinic, transportation, taking time off work. And these are some real life circumstances that even contribute to COVID-19. If you're a frontline worker, and we usually think about frontline workers as the healthcare workers, but no, the real frontline workers are those people who are working at the grocery store, in the gas station, in the fast food places. Those are the people who are at most risk of contracting COVID-19, especially early on. And these are the people who are facing the biggest challenge when it comes to making an appointment, because that means unpaid time off work, right? And getting transportation to make it to that appointment, that can become a challenge in itself. Taking public transportation in some areas is very challenging. Finding a ride to take you to that appointment, finding childcare while you're at that appointment. So these little nuances, like daily life challenges that sometimes we don't think about, that impact treatment in a big way. Now, I have to say there have been really major successes, though. So Ryan White program is extremely successful. The viral suppression rate of patients who are in Ryan White clinics far surpasses that patients who are not. We're talking about an average of 60 some percent for the US population, people living with HIV in the US, versus closer to 90% for those who are receiving Ryan White services. So, really successful program. Similarly, the PEPFAR program, the president's, I cannot remember the full abbreviation, but President's AIDS Relief Program that was established by President Bush has been one of the most successful global programs of the US, with countries receiving some of that funding surpassing the US in testing, in retention, in viral suppression. Some of them are at 95% viral suppression in their country. And that speaks to the importance of this global framework of diseases like HIV, like COVID-19, because what happens in Africa will impact the US, what happens in China will impact the US, either directly or indirectly. So when we invest in a smart way in this global partnership, and we let those people who are there lead these programs and lead them effectively with technical support, with capacity building, then we're able to achieve such outcomes. And this happened here locally with the Ryan White program that offers a lot of technical assistance, capacity building. And this also happened globally with the PEPFAR program, with the infrastructure that comes from that program, the capacity building, the technical assistance, the training, and investment in local leaders to lead these programs. I think this is a really good model to follow for so many other diseases and for so many other health conditions, whether they're emergency conditions or chronic conditions as well.
What a great testament to Ryan White. For some people listening, they may not know who he is, but he was a young boy. He wasn't a man. He was a young boy affected by HIV who became a very public spokesperson for the impact of HIV on children that become infected. His was through a blood transfusion for various reasons. Just bringing awareness to the fact that viruses enter our bodies in a number of ways. And we live in an ecosystem where that will happen regardless of who you are. And so to Ryan unfortunately did succumb to HIV. There wasn't treatment for him at that time, but to see that legacy 30 years later with this highly successful program that's making a difference in people's lives, what a great legacy for that program. I want to ask you a little bit about ECHO. You mentioned Project ECHO and how you went on to use that program during COVID, a time when we had to reimagine how to do global outreach without physically traveling.
Yeah, and we all know that now that Project ECHO has existed since 2007, and the first implementation was in New Mexico. to treat hepatitis C and train primary healthcare providers on how to treat hepatitis C with guided telementorship. And that program was extremely successful. And there have been different echoes here and there. When I was in North Carolina, there was also an hepatitis C echo. And when I came here, and I moved here in 2018, so COVID was very soon after. I was involved in so many nonprofit and community organizations trying to help Sudan, trying to help Sudanese Americans. I was a vice chair, or I'm still a vice chair of Sudanese American Public Affairs Association that has been there since 2013, trying to provide mentorship and support for Sudanese Americans, especially new immigrants. And then Sudan has undergone a major revolution in 2019 that toppled a 30-year-old dictatorship. And that dictatorship completely defunded the public health system. Only 2% of the GDP to maybe at best 4 to 8% was spent on healthcare. And there was a massive privatization of the healthcare sector that happened during that time. And healthcare just completely disintegrated, honestly, during that time. The public health infrastructure that we had in the country was quite dismantled. And that happened, the revolution happened in 2019. There was a transitional government that was put in place to bring the country to democracy. And right after that happened, COVID-19 hit the world. So we all had really amazing and big dreams for Sudan. Sudan was just removed out of the US state sponsor of terrorism in 2020 in the midst of COVID. And we were just really hopeful for a great outcome. Unfortunately, that didn't happen. But a lot of us Sudanese Americans and Sudanese diaspora were really invested in helping the country overcome this crisis, especially when COVID-19 hit, because we were already involved in some capacity before that. So we created what we called the Sudanese Coalition against COVID-19. And many of that was made of diaspora organizations from all over the globe. We had people from Australia, UK, Ireland, the Gulf, the US, and partners inside Sudan. So we fundraised, we delivered training to healthcare workers, and there were some really good outcomes out of that, such as installing hospital oxygen networks in some hospitals that didn't have oxygen networks, helping with the infrastructure of some hospitals and some healthcare capacity building. But we realized that the solution really starts at the community. If we only work at the healthcare sector, we're not going to be able to work effectively at addressing this disease. So we need some sort of community engagement. So in early 2021, Sudan was hit really hard by the Delta wave. And a friend of mine at Emory and myself, we started talking about how do we engage with the community, because the community was hearing all kinds of rumors, similar to ones we're hearing here in the US, about how COVID was made to, eradicate a third of humanity and this and that. And there was a lot of ambivalence about, masks and any kind of prevention. And people also needed to just get on with their daily life. It wasn't effective in such a poor country to tell people to stay at home and not go and work and make, daily living. So we had to figure out a way to engage in a smart partnership with community organizations. So we leveraged healthcare workers who were either newly graduating from medical school and not yet assigned to their residency, or we identified that majority of medical schools in the country were closed and other health professional schools. So there were tons of students sitting at home not knowing what to do. So we approached different organizations, student organizations, etc. And there was a major welcome of something like this because everyone wanted to do something, but they just didn't know what to do. So we had this amazing team on the ground and we needed to train them. At the same time, I was part of Project ECHO nursing home program here in the US. I was one of the subject matter experts participating in that. And one of our coordinators identified that, there is a major global program now working with Project ECHO to train healthcare professionals around the world. So we thought, this would be a great opportunity to bring Sudan into that. But because of there's so many different nuances when it comes to culture, etc., we figured that we need to figure out our own way of doing this. So what we did is that we approached Project Echo and paired the community medical response team that we had on the ground with Project Echo so that we can train them and deliver virtual telementorship. And there was a great welcome and thirst for that because I think the Echo model is so unique in the fact that it's not me sitting here telling you what to do, but it's this truly bi-directional and all teach, all learn model. So people bring real cases, real challenges, real successes from the ground and discuss those with subject matter experts. The didactic usually is like 20 minutes or 15 minutes sometimes, and the rest of the time is spent on case discussion, knowledge exchange, and sharing. I learned so much about Sudan from those echoes, things that I didn't even know. Sometimes you just feel like, yeah, this is my home country, so I should know. But even like the nuances of the healthcare system and how it operates from the locality level all the way to the Federal Ministry of Health level, I learned that through the ECHO program. And that helped us tremendously in figuring out how to intervene effectively. Because these real cases, the challenges that were brought, sometimes they were patient case, but sometimes they were actually systemic challenges that we needed to think about how to overcome. And that helped us refine the program, develop it as we go. So initially, we were focused on COVID-19 prevention. We then identified home management of cases of COVID-19 to be a big priority because the hospitals were overcapacitated and people needed to be managed at home. So we had to train healthcare workers on how to do that effectively through telehealth. And then we switched gears when vaccination became available to how to address vaccine hesitancy or lack of vaccine confidence. And we were there in the community day in and day out, and volunteers were really engaged in collaborating with community leaders, with community healthcare workers in addressing many of these challenges. And when vaccines became available, we collaborated with the Ministry of Health and we started a vaccine campaign and mobile clinics. And that was such an effective program. It was just incredible to see the success of this. The first vaccine clinic we held was in a locality in the capital, Khartoum. And there was a lot of hesitancy from our collaborators and partners, and even the Minister of Health, of this becoming successful. But there were a couple of awareness campaigns conducted before the vaccine clinic. And on the day of the vaccine clinic, we ran short of vaccines. So we had delivered 500 doses by 1 p.m., and staff had to go back to the Ministry of Health to get more vaccines. So by the end of the day, we had delivered 2,000 doses. And that was just such a remarkable story. And what was really neat about this is an idea that I actually got from here, from Omaha. Because early on, during early days of COVID vaccination, vaccines were not accessible in North Omaha. And North Omaha is where the majority of African Americans live in Omaha. Omaha is a very segregated city with lots of history around redlining, etc. So North Omaha did not have enough vaccines. So we actually started a mobile clinic. There is a group of us, mostly Black women, and we have this fearless leader and fearless community collaborator who were just like, let's do this. And they identified the location. We all went volunteered. And I'm like, this is interesting. Maybe we can replicate that back in Sudan. And this is why the globe is just such a small place, because the same experience that worked here to address health inequities in vaccine distribution worked in Sudan in areas that the vaccine were not accessible. So this knowledge exchange has been such a tremendous way of being able to help. I haven't been to Sudan since COVID started, but I have been able to mentor and exchange knowledge and collaborate with so many people that I can't even count. We have about 14 organizations right now that are partner organizations, in addition to several Ministry of Health and localities, etc. And this was all done virtually and remotely.
That is awesome. So this brings us to the really the new future with telemedicine, telehealth, telementoring being such a powerful tool for us to address global healthcare capacity and equity. We at Healthcare Alliance believe that we can really scale the current healthcare workforce that we have through the power of telehealth to use the hundreds of years of training and experience that exists in the global healthcare workforce and leverage that to provide care anywhere in the world. There are 13 million doctors in the world. If we could get just 1% of that 13 million to give 2 hours of their life out of a whole year to be on a video, we would have 700 extra hours of physicians every day. And we could do that for everything. We could do that for therapists. We can do that for nurses, never as a means of replacing in person healthcare, but as a means of augmenting in person healthcare, because there's a shortage of 15 million doctors in the world. And you can't fix that for many lifetimes. And who has to wait for it to happen in the meantime? Who has to go without care and suffer because that doesn't exist? So it's an amazing way to leverage the healthcare workforce we have. And you mentioned two really important communities in that healthcare workforce. You mentioned diaspora communities. We've interviewed a lot of people on this show, and many of them are immigrants from other places. And just that drive to always want to help your, not just your community, but just understanding that there's communities like your community and wanting to help comes from being part of that immigrant experience. And you mentioned trainees in medical education. This is an untapped, unappreciated resource. This is their future. We have lived the in person future and are winding down with telehealth at the end of our careers, but this is their future. This is the modality that'll be an everyday part of their life. And this is an amazing opportunity to make global health part of their education now, today. I would love your opinion on those two things: the role of diaspora communities in helping build healthcare capacity, whether it be in person, which is really resource intensive. It's not very scalable for people to give up their families, give up their lives and travel. And then it creates the ability to only do a time limited intervention, which is great. If you're talking about surgeries and you're going to go and do a bunch of surgeries, that's wonderful. But then telehealth gives us the ability to stay connected in between, to have an ongoing presence and also an ongoing interaction with the healthcare system and to help build it and reinforce it. And then the role of medical trainees in this possible future.
Yeah, absolutely. And I love those statistics that you shared because, I think if you think about it in numbers, you're like, wow, this is really an incredible solution. And speaking as a diaspora myself, I feel like this telehealth, telementorship, teleeducation, digital learning, all of those, virtual global health, all of those things, this is a wonderful way to reverse the brain drain that Africa and other places have suffered for so long. We always talk about this, human resource for health shortages and crises in Africa and the brain drain. I just looked at some statistics recently. 60% of Sudanese physicians live abroad today. And these are Sudanese physicians who trained in Sudan, who went to medical school in Sudan. So there is major resource, unfortunately, loss in the country. We invest in these people, we train them, they go to medical school, and then now they're gone afterwards. But most of them actually would be more than willing. There was a survey actually done of Sudanese diaspora physicians, and 78% of them said they would be more than willing to give back to their country. And when they asked them how are they giving back, it was mostly, I go back and give a lecture, I go back and do surgery when I'm there. Usually this is on my personal visit time, my personal vacation. Usually it's personal initiation of this project rather than, having a coordinated system to coordinate it. So if we do that in a virtual digital platform, it has an incredible potential. It could be a way to actually deliver healthcare directly. It could also be a way to train people to deliver healthcare. It could be a way to do both, deliver healthcare while training people. So there is so much potential of that. And actually, that's how we kind of started the CMRT program. The main driver is that I was here in the US managing 10 patients a day in Sudan. And these are family members, my friends, friends of family members, etc. They just know that I'm an infectious disease doctor, and then all of a sudden I see a WhatsApp message, hey, can I ask you a question? My mom, has these symptoms, etc. And I'll be following up with them, and then I'm like, I only have so much capacity. There's time difference. I need to figure out how to do this effectively. And then we thought about training healthcare workers there so that they can do this. And we'd be there as their mentors, very close with them and follow up, and leveraging also local physicians because local physicians have a lot of understanding in the context. So this has to be a collaborative effort, appreciating what the local healthcare workforce has to offer, appreciating what the diaspora can bring in, resources, and easy access to knowledge. Because I think that's the advantage of us over somebody who lives there. Is not we're not smarter, we're not really brighter in any way. We just have easy access to knowledge and easy access to information. So if we can do it that way in a collaborative manner that empowers local people to take the lead, it can be a tremendous success story. Trainees are absolutely amazing. I mean, I'm learning so much from my students, even in my specialty areas of DEI, diversity, equity, inclusion. A lot of the momentum behind DEI came from students and trainees wanting to see a change, wanting to see emphasis on health equity. And that's just usually an amazing driving force. And this new generation is built literally on digital platforms, right? Like it's if I need to get hold of my son, I have to text him, right? So if I call him, he's not going to answer. So this is the life they live. This is day in and day out for them. And you give him an iPhone and he can solve all the problems with your iPhone in a minute while you've been struggling all day to figure out which button to click. So why don't we leverage that knowledge, that intuition towards digital technology? I think that's really something important that we need to think about for the future.
And this brings us to the aspirational part of the podcast. If you could wish for anything, magical, anything, no holds bar, if you could wish for anything to address health inequity, whether it be in the United States, Sudan, or globally, what would be your one great wish?
Oh boy. so, so I think I'm unfortunately going to give you a long answer for this because one of the biggest lessons I learned from digital um, networking and digital learning and virtual engagement is that you can respond to things extremely quickly. Like COVID started, we were able to respond very quickly through digital learning. The war started in Sudan, and within 2 weeks, we had a training program up and running with thousands of people attending. And that could not have happened in any other way, shape, or form if we didn't have the digital technology that we have right now. So if I had to wish for something, and this is a very modest wish, I'm a very modest person, and I'm very realistic. I wish that internet was accessible all over the globe because that would have made the world a much better place right now. I mean, we take this for granted, right? We're sitting here talking, communicating. Maybe our videos will glitch every now and then, but I could never sit down and have this conversation with somebody in Sudan because we will have hundreds of glitches while we're having this conversation. We could not have Zoom meetings with our Sudanese partners. So we actually had to switch our whole operation of Echo from Zoom to Telegram because Telegram is like this very low bandwidth social media app where we can actually have conferences and share slides and etc. And that accessibility of internet is going to be the biggest inequity that we're going to see in this next century because this will divide the world in such a way that it will augment inequities in such a big way. So if I could wish for something, very modest wish, I wish internet was all over the globe.
That's an important wish. And so, if we have internet service providers, tech providers listening in, we really need for rural places, the places that people aren't going to be able to get to, whether it's conflict, whether it's pandemic, whether it's weather events, flooding, other natural disasters. We can connect with them and make life better for them if we just have internet service. Dr. Fadl. I'm going to make my wish that Doctors and other healthcare professionals take up the mantle of leadership in making health equity move forward. The Calvary is not coming, the Calvary is you. Connect with each other. We are definitely building a community here. Connect with each other and carry it forward. It's the Calvary is you. That'll be my wish. Netta, how can our audience connect with you?
Well, this has been an amazing conversation and I have really enjoyed it. I would be more than willing to connect with anyone who has any ideas or would like to collaborate, and happy to share my email. I can spell it out, but I'm happy to also share it so you can have it in the script of this. So it's Nada, Nada, dot Fuddle, F as in Frank, A as in Apple, D as in David, UL, at UN as in Nancy, M as in Mary, C as in cat, dot edu, unmc.edu. And very grateful for this opportunity.
Oh, it was such a pleasure. And our audience is going to gain so much knowledge about what you do. But we've learned so much about the amazing work and career that you're carrying on, and so many more things to come. Really a pleasure to connect with you and have this wonderful conversation. In this podcast, we have frequently highlighted and explored the vital role of collaboration between public and private enterprises, backed by government support for sustainable health equity innovation. If you are a minister of health, other public health officer, working to enhance healthcare access and equity, please, we want your voice on our show. Share your valuable insights and perspectives with our audience. Contact me at Dr. T, Dr. period T, at haew.org to secure your spot on the podcast. Listeners, please, we need your support too. Please share today's episode with a friend. Dr. Fuddle's insights are amazing. Please share it with others that would want to learn and experience her amazing career and her amazing innovations. Leave us a review and share your thoughts. If you're interested in being a guest, please email us, and please visit https://haew.org to learn more, join us, partner, or contribute. Together, let's amplify the conversation for a healthier and more equitable world.